Hey everyone, this week we will be discussing acute kidney failure, also called acute kidney injury, which is a sudden decrease in renal function. And it does tend to be reversible if they can figure out the cause and treat it appropriately. We are also going to discuss chronic kidney disease, which is a significant decrease in kidney function. This happens over a long period of time and it is irreversible. Now, let's review how our kidneys work. And we're going to look specifically at the nephron, because whenever we're talking about a decrease in renal function, we're really talking about this glomerulus and how it is filtering, specifically the glomerular filtration rate, or GFR. So we'll be using that term a lot, and if you can understand the GFR, everything else tends to make sense. Okay, so the nephron is the functional unit of your kidney that actually produces the urine. And in each kidney, you have millions of these nephrons. And their whole goal is to filter our blood that it receives from the heart. And the glomerulus is the structure that does that. So it filters all these substances such as water ions, which are your electrolytes and bicarb. And it also filters things like urea and creatinine, which are waste products. Remember, urea is a waste product from protein breakdown in the liver, and creatinine is a waste product from the breakdown of muscle. An important thing to remember is the glomerulus does not filter proteins and blood cells. You should not find them in your filtrate unless your glomerulus is messed up. Then the filtrate drips down into the Bowman's capsule, and then it's going to go down through the renal tubules. The renal tubules are, in a sense, tweaking that filtrate and reabsorbing what the body needs to maintain homeostasis. So it's going to reabsorb the amounts of water you need, it's going to reabsorb a little bit of urea, and it's going to reabsorb the electrolytes that we need. However, it is not going to reabsorb creatinine. Let's talk about creatinine for a second. So creatinine is a waste product, and it's solely filtered by the glomerulus from the bloodstream, and it's not going to be reabsorbed in the renal tubule. So that's why we care so much about creatinine. We measure it in the urine and the blood because it gives us a good indicator of how well that glomerulus is filtering the blood. A normal creatinine level is 0.6 to 1.2 kilogram per deciliter. Whenever we measure our glomerular filtration rate, we take a lot of things into calculation, such as their creatinine clearance level, the patient's gender, their age, their race, and their weight, and that helps us determine that. Think of your kidneys as a smart filter. It can choose what to keep and what to get rid of based on your body's needs. So, whatever your body doesn't need or has too much of, your kidneys will filter into the urine. Anything it needs, it keeps. Which is why if your kidneys aren't working appropriately, you will typically have high levels of electrolytes and waste products in your blood because your kidneys can't filter them out. Now let's start with acute kidney failure and its pathophysiology. An acute kidney failure, also called acute kidney injury, AKI, which is what I will call it for the remainder of this video, is a sudden short-term loss of kidney function, and if not stopped or reversed, can lead to chronic renal failure. So, when the kidneys aren't able to filter the blood like they should, you get buildup of electrolytes and waste products such as creatinine and urea. You will also see fluid buildup in the patient because, again, those kidneys cannot remove the excessive fluid from the blood. AKI can result from three types based on where it is located in the body, which are prerenal, intrarenal, and postrenal. Let's cover the prerenal first. So with prerenal AKI, you have decreased blood flow perfusion to the kidneys. So a memory trick you can use to remember is to think of decreasing perfusion with prerenal. In prerenal, oxygen-rich blood can't get to the kidneys. This decreased blood flow means decreased oxygen. Think of it like this. Oxygen is the money of the body. No money, no honey, no oxygen, and the body goes broke and dies. Kind of like the kidney is suffocating to death. Now, this is typically caused by obstruction or vessel occlusion, where we have a blockage of blood flow which blocks the oxygen. This can be from an emboli or a blood clot, or even a tumor that blocks the perfusion into the kidneys. Another cause is from low blood pressure. In patients with shock, sepsis, or anaphylaxis, dehydration, and hypovolemia from major blood loss or blood volume, it can cause that low blood pressure, which means a low perfusion, and that is equated out to less than 65 mean arterial pressure, or a MAP. Lastly, with low cardiac output, we get low perfusion. So just think of it this way. Low cardiac output means low oxygen put out of the heart, resulting in a low perfusion to the kidneys. Typically, when the heart can't pump correctly, it decreases blood being pumped out of the heart. We can see this with ECG dysarrhythmias and myocardial infarctions, and even in clients with heart failure, which is a little bit counterintuitive, so listen closely. Even though we may have high blood pressure with heart failure patients, the big problem is low cardiac output. We get low volume of oxygen-rich blood out of the heart, and this results in a low perfusion and less oxygen carried to the kidneys. Next, we have intrarenal. That's direct damage inside the kidney itself. Think in the renal for intrarenal. Now, let's dig into the specifics here. This is far more serious because it's more intense with intrarenal. It's also referred to as acute tubular necrosis, or ATN. So I just think ATN requires immediate attention now. Typically it's caused from infections like pyelonephritis, which results in glomerular nephritis, or even autoimmune diseases like lupus, where the body attacks itself, which results in a nephrotic syndrome. A patient may also have intrarenal damage from prolonged ischemia to the kidneys. The top two external causes for intrarenal are CTs with contrast dye. So just remember, contrast kills the kidneys. And antibiotics ending in myosin, like vancomycin or gentamicin. So just think it's a sin to give a myosin. And last but not least, we have postrenal. A memory trick would be to just think past the renals. So in postrenal AKI, there's a renal blockage after the kidneys, which basically blocks the outflow of urine. So urine can't get out of the kidney itself. This causes a lot of pain and pressure and strain on the renals. It can happen from a mechanical obstruction, such as in patients with a renal calculi, also known as kidney stones, that get obstructed in the ureter after it passes the kidney. It can happen with tumors or benign prostatic hyperplasia, BPH, where we see these big swollen prostates. Or it can happen in prostatitis that typically occurs from STDs. Now, let's discuss the 4 stages of AKI. So, number 1 is the onset of injury, known as the initiation stage. And just as the name tells you, this is when it all starts. So, it starts whenever there is something causing the kidney to become injured, either prerenal, postrenal, or intrarenal. And it ends when the signs and symptoms start to appear. This stage can occur in a few hours to several days. And this is really when you want to find out the cause and treat it to prevent the long-term damage to those nephrons. Because if it's not corrected soon enough, they can enter into the chronic renal failure, which is what we will be talking about in a few minutes. Now, after the initiation phase, patients can go into what's called the oliguric phase. It's important to note that some patients will actually skip this stage and enter into the next stage, the dialysis stage, but the oliguric stage is an important stage to know. So just think of the O's and oliguric. Oliguria is considered urine output less than 400 milliliters per day, or 20 milliliters an hour. Memory trick. Urine output of 30 milliliters per hour or less means the kidneys are in distress. So, at 400 milliliters in 24 hours, well, that's really, really low. And just think, very sticky, thick urine. So, the memory trick we can use is if the urine is dry, then the specific gravity is high. The glomerulus is not filtering well, so you will see a decreased GFR as well as an increased BUN and creatinine. Symptoms of the oliguric stage are neurocognitive changes. They're going to be really confused, they're going to be sluggish and tired and sleeping all the time, And they can also itch really bad. And that's because the urea waste has built up in their skin and it's causing that itching. Our next stage is called the dialysis or diuresis stage. And this is where our nephrons are on their way to recovery, but they're not 100% yet, but they're getting there. So just think diuresis, D for drain in urine, and dramatically high urine output, which is gonna be like 3 to 6 liters per day. So why does that happen? Well, the kidneys are basically trying to flush out the problem, which means they are trying to get rid of all of that collected waste material. And a lot of that's going to be urea, which can cause an osmotic diuresis, which is great, right? We want to get rid of those fluids. Well, they're getting rid of all that waste product in the body, and they're getting rid of all of that edema and all of the high electrolytes. All good things, right? Well, in the previous stage, the patient was fluid overloaded. Now, they're fluid depleted. They're going to become hypovolemic, and then that puts them at risk for dehydration and hypotension. And whereas before we were struggling with hyperkalemia, now they're voiding so much and we're pulling that potassium into the urine, they can become at risk for hypokalemia. Also, that urine is going to be really diluted. It's going to put all that fluid into the urine. And so that specific gravity is going to be really low. But good news, the patient will start to become more alert and oriented, especially compared to how they were in the previous stage. Treatments can include supplements to replace those electrolytes. So they may be getting an electrolyte infusion, they can be getting IV fluids, which seems like a paradox for someone who's in renal failure. But if they're in this stage, they need it so they don't go into that dehydration. Now, this stage can last anywhere from a week to 3 weeks. Okay, so after they go through this stage, they hit the last stage called recovery. And this starts when the GFR returns to normal. Their BUN and creatinine start to return to normal, and they are avoiding about 1 to 2 liters per day. So just think R for recovery. And that also represents R for really slow recovery, since it can take upwards of a year to fully recover. Some patients, unfortunately, never make it to the recovery stage because there's just too much damage. And instead they develop what's called chronic kidney disease, which we will be discussing here momentarily. As far as assessment findings, these are pretty simple. For memory tricks, I love to use acronyms. For this one, we'll use the acronym HOOC, H-U-C, since the kidneys kind of look like a pirate. So, H is for hydrogen ions, which are very acidic. U is for urea, and C is for creatinine. So, the key numbers to know is creatinine over 1.3 is bad. BUN over 20 is also bad. A urine output of 30 milliliters per hour or less means the kidneys are in distress. And metabolic acidosis is a pH below 7.35. This is typically due to the retention of all of those hydrogen ions, which pushes the body into an acidotic state. The treatments are pretty simple here. The main goal is to prevent major kidney damage, and we do this by flushing the kidneys with the fluid bolus, or with diuretics. We're basically trying to push the kidneys from the oliguric phase into the diuresis phase. Now we're going to talk about chronic kidney disease, CKD. And as I said earlier, it is where we have a significant decrease in renal function. This happens over a long period of time, and it is irreversible. With CKD, we really pay attention to that GFR. In CKD, GFR progressively decreases, and there's various stages of it. So for exams, I would be familiar with the GFR for each stage, especially stage 4 and 5, because that's when you have that severe loss of renal function. So let's go over this. Stage 1 is where they have kidney damage with normal renal function. So their GFR is going to be normal, which is greater than 90 milliliters per minute, but there's going to be proteinuria, which is protein in the urine, and that's typically presented for 3 months or more. Then they can progress to stage 2, which is kidney damage with mild loss of renal function, with a GFR between 60 to 89 milliliters per minute. And they will also have proteinuria that's been present for 3 months or more. Then stage 3 is mild to severe loss of renal function, with a GFR between 30 to 59 milliliters per minute. And then we go into the really severe stages. Stage 4 is severe loss of renal function with a GFR between 15 to 29 milliliters per minute. And then the very last stage, which is the worst stage of all, is stage 5. And this is end-stage renal disease. And this is where the GFR is less than 15 milliliters per minute. And this is where the patients are typically going to be getting dialysis regularly, either Monday, Wednesday, and Friday, or Tuesday, Thursday, Saturday, essentially every other day. They'll also be a candidate, they may be a candidate for kidney transplantation. Therefore, as the GFR is decreasing, the patient is going to have issues. They're going to be having issues with waste, with electrolyte imbalances, and with fluid overload. And as you've seen in those stages, as they go from stage 1 to stage 5, that GFR is progressively decreasing. So in the patients that are in the early stages of kidney disease, they're probably going to be pretty asymptomatic because that GFR is normal, compared to the patients that are in stage 4 or 5 where the GFR is really low. So this is really what we're going to be concentrating on, are those patients who are in the last stages of chronic kidney disease, when we have a decreased GFR and increased creatinine and increased BUN. So think of it this way, everything that should be filtering is just staying in the blood and it's building up. So with CKD, those waste levels are going to be high, and this is going to lead to problems such as azotemia, uremia, neurological changes, and itching. Then what's going to happen to our fluid status issues? Because the glomerulus is not removing water as it should. So we're going to get fluid overload. We're going to be hypovolemic now. What's going to happen with that? Think about when there's too much water in your body. We have a lot of pressure in there. Our blood pressure is going to be high, hypertension. This can lead to a lot of pressure on the heart, which then can become weak, which then can lead to fluid backing up into the lungs. So pulmonary edema, cardiac issues, things like that. All right, so how do you expect the urinary output to be if this glomerulus is not filtering the way it should? Will the urinary output be high or will it be low? It will be low. Okay, but what is considered low or oliguria? Well, oliguria is considered a urine output of less than 400 milliliters per day or 200 or 20 milliliters per hour. And anuria is urinary output with less than 100 milliliters per day. So you'll be seeing some really low urinary output in these patients. Okay, so now let's remember back to last week's lecture on fluid and electrolytes. And this next section will also apply to acute kidney injury. So when the glomerulus is not removing the ions as it should, you are going to get some electrolyte disturbances. So which electrolytes are going to be high? Number 1, our potassium. And we really care about potassium because it can cause cardiac issues. So we're going to have hyperkalemia. How's our phosphate level going to be? Well, those are going to be high as well, along with our magnesium levels. Okay, so what about calcium levels? Well, remember in our fluid and electrolyte lecture, phosphate and calcium have a relationship and they are always the opposite of each other. So whenever you have high phosphate levels, you're also going to have low calcium levels. So why is that? Well, calcium binds to the phosphate. So we have all this phosphate in our blood. It's going to take the calcium and bind it to itself, which is going to remove the calcium from our blood. So we'll have hypocalcemia. Now, let's take it a little bit further. What's going to happen with all of that? Well, whenever your parathyroid gland senses the high phosphate levels, it causes the parathyroid gland to release parathyroid hormone, PTH. But you may be asking, what does the parathyroid hormone have to do with anything? Well, then that stimulates the bones to release calcium from within themselves into the blood to try to help balance it. So it tries to increase those calcium levels in the blood, But you guessed it, it's also going to pull that calcium from the bones, and it's going to make those bones weak and brittle when it's done over time. So keep that in mind for whenever we're talking about nursing interventions. So we're going to have hyperkalemia, we're going to have hyperphosphatemia, we're going to have hypermagnesemia, and we're going to have hypocalcemia. So we are going to see a lot of electrolyte disturbances with these kidney failure patients. Not only is the nephron being affected, but the whole kidney and the cells within it that secrete hormones and activate vitamin D are also going to be affected. Our glomerulus should not filter protein and blood cells, but in chronic kidney disease, because the whole structure is being affected, you will typically see blood and protein in the patient's urine. So what's going to happen when they're losing all of this protein in their urine? Well, we know that albumin is one of those proteins that regulates onconic pressure. And whenever you have a decrease in onconic pressure, it allows fluid within the capillary to leak into that interstitial tissue. So we're going to get even more swelling and edema. Then, with the hematuria, we're losing red blood cells in our urine. We're going to get anemia because we're losing blood into the urine. The anemia leads us right up to our next topic, which is the kidney's production of hormones. One main hormone they produce is a hormone called EPO, which is short for erythropoietin. And what does that do, you say? Well, it helps create red blood cells in the bone marrow. And in CKD, EPO is not being produced like it should, which is going to do what exactly? Well, it's going to slow that production of red blood cells, which is only going to worsen the anemia they already probably have because they're peeing out all of those red blood cells already. Another hormone the kidneys produce is called renin. And renin plays a role in increasing our blood pressure. And how does renin increase our blood pressure, you ask? Well, I'm glad you asked. The cells within the kidneys that release the renin are constantly reading how much fluid is going through the glomerulus. And when there isn't a lot of water getting filtered through, the cells go, uh-oh, the blood pressure must be low. And the cells release the renin to increase the blood pressure, which is not a good thing because remember, we're already in a hypervolemic state. We're already going to have hypertension going on. So we're going to release more renin, which is going to increase our blood pressure even more. And here in a second, we're going to talk about the causes of CKD, and hypertension is one of them. So we're causing even more damage to our kidneys. And another thing that the kidneys do is to activate vitamin D, which plays a crucial role in helping our bodies reabsorb calcium from the food we eat. But with CKD, they're not activating that vitamin D. So guess what? They are not going to be reabsorbing the calcium that they have eaten. So they're going to be even more hypocalcemic, which remember, with the high phosphate levels, they're going to have even lower calcium levels. So that's going to be a double whammy with our calcium. Now let's look at the causes of chronic kidney disease. Okay, one cause is diabetes mellitus. Well, how does that cause CKD? Well, when the patient has uncontrolled hyperglycemia, so they have a lot of glucose in their blood. And this causes glucose to stick to the artery wall, and that causes damage to those arteries that supplies blood and oxygen to the kidneys. So they develop chronic kidney disease because their kidneys are being deprived of the nutrients they need to function. Another thing that can cause CKD is high blood pressure. One of the unfortunate things with hypertension is there really is minimal signs and symptoms until it's too late. It's like a silent killer. A lot of times the patient is totally unaware that they even have the high blood pressure. So there's this constant high pressure hitting those artery walls to the kidneys, and then they become damaged, which whenever the artery that's feeding the kidneys becomes damaged, that's less blood that's going to make it to the kidneys and go to the nephron, which will then further the kidney damage even more. Think of it this way. If you take a hose, regular running hose, and you put it over a sandstone wall, and you're just spraying that sandstone wall, it may make it a little bit more smooth. But if you take your finger and you put it over the tip of the hose and spray it and increase that pressure and spray it on that sandstone wall, you're going to start getting these broken pieces and flyaways, and it's going to really break up that sandstone wall and cause damage. That's kind of what high blood pressure does to those delicate nephrons in our kidneys. So these two diseases, these two issues, are the most common causes for developing chronic kidney disease. Other causes can include acute kidney injury, acute renal failure that we were talking about earlier in this video. Maybe they don't progress to the recovery stage of the disease and they progress to the chronic kidney disease instead. Polycystic kidney disease, which is a genetic condition where cysts develop in the kidneys, causing issues with the renal function. Infection or nephrotoxic drugs. Those drugs that can be very, very toxic to the kidneys, like NSAIDs, aminoglycosides, chemotherapy drugs, or contrast dye for testing procedures. Okay, so what is the treatment for chronic kidney disease? Remember, we have various stages. So in those earliest stages, where the GFR is normal, the main treatment is to treat the underlying cause. The patient needs to get control over their blood pressure, they need to get control over their blood glucose levels so they can prevent further damage to the kidneys and hopefully preserve that current GFR that they have and not decrease it anymore. Also, the patient may be prescribed blood pressure medication to help keep their blood pressure under control and to help protect the kidneys. And there's actually two groups of medications that have been found to actually provide a protective mechanism to the kidneys. And they include ACE inhibitors, which are angiotensin converting enzyme inhibitors. A good way to identify ACE inhibitors are medications that end in pril, like lisinopril or enalapril. The other drug class are the ARBs, the angiotensin receptor blockers. A good way to identify ARBs are medications that end in sartan, like losartan. In addition to blood pressure and sugar monitoring, the patient should be getting their GFR monitored regularly and making sure that they're not getting progressively worse. Now, when the patient progresses or in those advanced stages, like stages 3 and 4, a nephrologist should be on board and following the patient. When the patient reaches stage 4 is when the nephrologist typically starts looking at placing a fistula in the patient because in the last stage, stage 5, the patient may need dialysis on a regular schedule, typically 2 to 3 days per week, getting dialysis every other day. So what is dialysis? Well, it's a machine that's going to take the blood and filter it like how the nephron of the kidney should have. So it's going to help remove excessive water, the waste, and regulate those electrolyte levels. Now let's look at our nursing interventions, which applies for both AKI and CKD patients. What are we going to do for these patients as the nurse? Well, let's ask yourself what is going on with this patient and those late stages of kidney disease. Well, they're going to have a buildup of waste in their blood. They're going to have anemia. They're going to have electrolyte imbalances, low urinary output, and fluid overload. So we want to tailor our nursing interventions based on what's going on with the patient. So first, let's look at the buildup of the waste in the blood. Patients are going to have what's called uremia. And whenever they have this, they will have some specific signs and symptoms because remember, our GFR has decreased. So it's not filtering out all that waste anymore. So that waste is trying to go somewhere. One thing they can have is itching. And this is due to deposits of urea crystals on the skin. It's going to secrete through the sweat glands and it really has a unique look to it. It actually looks like this white frost on the skin. And this is known as a uremic frost. Another thing the patient can have because of high waste products in the blood is they can have confusion. So you need to be assessing their neurostatus. And because of these neuro changes, they're going to be at risk for injury of falls. So you want to be thinking about the safety issues. Also, the blood is going to become really acidic from all this waste in there. So the blood pH can be less than 7.35, and they can enter into a metabolic acidosis. And whenever that happens, you may see what's called cosmol's bleeding. These are deep, rapid breaths, and it's the respiratory system trying to blow off carbon dioxide because carbon dioxide is acidic, and it's trying to increase the blood pH. So make sure you're watching the respiratory status, counting those respirations. We will also be seeing anemia. And we'll be seeing anemia because these patients have a low production of EPO and they're losing blood in their urine, along with being deficient in other minerals such as iron and folic acid and vitamin B12, and those substances play a role in helping us produce hemoglobin. Some treatments for anemia can include iron infusions or iron tablets to help replenish those levels and help produce more red blood cells. Also with EPO shots, and these are given sub-Q typically every other week or once a month, and this will help stimulate the bone marrow to produce more red blood cells. And lastly, they can get a blood transfusion, but that's really kept on the back burner while other things are tried first. Okay. Another thing we had going on was low urinary output and fluid overload. So anytime we're dealing with fluid issues, we're going to monitor their intake and output very, very closely. We're also going to perform daily weights because weighing patients and looking at their weight is a good indicator of fluid retention. Also, if they're in fluid overload, the heart may be becoming weakened and you may get an S3 heart sound with that weakened heart. And then the weakened heart allows fluid to stay in the lungs or flow over into the lungs. So you'll be paying special attention to the lung sounds because when you hear crackles, especially those real fine crackles, that can indicate pulmonary edema. We're also going to monitor their blood pressure because we want to keep their blood pressure in a normal, good range. Not too low, not too high. Because remember, high blood pressure is really hard on those kidneys, but low blood pressure doesn't give it the perfusion that they need. Okay, now what type of diet would you want them to follow? We want them to follow a low protein diet because remember, urea is the breakdown of protein in the liver. So we want them to have some protein to prevent muscle wasting, but we don't want them to have high amounts because it's just going to be broken down into even more urea, more waste than our kidneys can get rid of. Another thing that may be ordered by a provider is fluid restriction. We want to watch their urinary output really closely and make sure that we're not giving them or allowing them to have so much fluids compared to what their kidneys can actually manage and put out. The patient will also likely be on a low sodium diet because sodium loves water. So the more sodium they have in their system, because they're not really excreting the sodium as they should, that draws more water into the vascular system, which, you guessed it, can increase their blood pressure even more. Another thing we want to do is restrict the foods that are rich in potassium. Those foods include things like potatoes, avocado, strawberries, bananas, spinach, and oranges. Because with these patients, as stated before, they aren't filtering out the potassium. And with high potassium, they are at risk for cardiac events. That brings me to my next point. We really want to monitor their ECG and have them on a bedside monitor. We're looking for any tall peaked T waves. Also, the QRS complex can widen and their PR interval can get long. Another electrolyte imbalance patients will likely have is hyperphosphatemia, where they have high phosphate levels, which also contributes to the hypocalcemia, along with the decreased ability of activating that vitamin D in the kidneys and the parathyroid as discussed earlier. Fortunately, we can help bring down the phosphate with phosphate binders. So what these drugs do exactly is they bind with the phosphates in the food and help the body excrete the phosphates in the stool. So ask yourself, when is the best time to give phosphate binders? These meds are best taken with meals or like 5 minutes before meals or immediately after because we want them to take it with the food because it's working best while being able to absorb the phosphate directly from the food in the stomach so it can excrete it out of the stool. You will also want the patient to follow a low phosphate diet. So this will be to restrict foods like poultry and fish, dairy products, nuts, especially your canned sodas that have phosphate in them, and oatmeals. Lastly, because the patient is at risk for hypermagnesemia, usually because they have a low calcium level, because those two go hand in hand, as we learned last week in the fluid and electrolyte lecture. So what you want to remember with this is you want to avoid any magnesium-based antacids or laxatives, because you're just giving them more magnesium, and you want to make sure you're restricting those foods high in magnesium as well. So this wraps up our video on AKI and CKD. Happy studying!